Hello everyone, welcome to the APSC President Session at JCS2025. So I'm Toshi Sanzai of Hokkaido University and Japan, and I'm going to chair the first session regarding ACS with Professor Yi Hanley. And so first, we'd like to welcome President Dr. Yoshio Kobayashi for opening remarks. Dr. Kobayashi, please.
Welcome to the Japanese Circulation Society Annual Meeting 2025 in Yokohama. I'm Dr. Kobayashi. I'm currently the president of the Japanese Circulation Society. It's an honor to have you, have distinguished members of the APSC in Japan. Now we face destabilization in the world. So, close collaboration between Asian countries is important. Today, we discuss the topics of acute coronary syndrome and atrial fibrillation. I'm sure we'll have a hot discussion. Again, I appreciate you attending the APSC President Session. Thank you for your kind attention.
Thank you very much, Professor Kobayashi. Now we'd like to start the session 1, ACS in APSC. The first speaker is Professor Yi Hanley from Taiwan. He's going to give us the keynote lecture. Professor Lee, please.
Thank you very much for the chairman's introduction. Ladies and gentlemen, good afternoon. First of all, I would like to thank the Japanese Circulation Society for organizing this great session and inviting me and give me the opportunity to give this talk. So I'm going to share with you the current antiplatelet strategy for acute myocardial infarction currently in Taiwan. And this is my disclosure. So probably every doctor in this room knows that the dual antiplatelet treatment is the current standard therapy for the patient with acute myocardial infarction. However, in the East Asian regions, the choice of the DAPT strategy is a little bit different among the countries. Currently in Taiwan, for the available P2Y12 inhibitor, there are clopidogrel and the ticagrelor and the low-dose prasugrel. In Taiwan, we don't have the standard dose, the prasugrel. So why there's a difference across the Asian region about the DAPT strategy? I think there are several major reasons. The most important reasons is about the East Asia paradox. That means for East Asian patients, usually we have lower thrombogenicity, but we have higher instance of the bleeding risk. So this reason influence the choice of the DAPT strategy for our ACS patient. So there are several other strategies in these regions. For example, we use the reduced P2Y12 inhibitor dose, like the low-dose prasugrel, or we use the short-term DAPT, then followed by antiplatelet monotherapy, or we use the early P2Y12 inhibitor monotherapy, and so far. So all these strategies that reduce the standard intensity of the DAPT, we call it as a de-escalation strategy. So in Taiwan, we perform a study to evaluate the antiplatelet strategy, including the use of the de-escalation therapies for the acute myocardial infarction patient undergoing PCI. So we used the National Health Insurance database and included adult patients who received PCI for acute myocardial infarction and survived to discharge with DAPT. To avoid the influence of the complex antithrombotic regimen, patients who need oral anticoagulant were excluded from the study, like the patient with atrial fibrillation, the patient with deep vein thrombosis, or patient with mechanical valve. We excluded those patients. So from 2011 to 2021, in this study, we included almost 60,000 patients with acute myocardial infarction that received PCI with stent and survived to discharge with the dual antiplatelet therapy. So first of all, we look at the depth we use in Taiwan at discharge. You can see that the figure here shows the percentage of the different strategy. So after 2013, after introduction of the ticagrelor to Taiwan, it was used very rapidly. So into 2021, right now in Taiwan, for total patients with acute myocardial infarction, right now around 70% percentage of patients were treated with aspirin plus ticagrelor at discharge. Right now, the clopidogrel use reduced to about 20 to 25%. And in 2019, we have low-dose prasugrel. So in 2021, right now, around 5% of patients, we use the aspirin plus the low-dose prasugrel. So the choice of depth between STEMI and the non-STEMI is a little bit different. For STEMI, you can see in Taiwan right now, around 80% of the patients were treated with aspirin plus the ticagrelor at the discharge. But for non-STEMI, only around 60 to 70% patients were treated with standard aspirin plus ticagrelor. However, after discharge, in those patients who received aspirin plus ticagrelor, more than half of them will receive de-escalation strategy after discharge. So you can see the figure here shows the percentage of the patient who received the de-escalation of the treatment after discharge in those originally treated with aspirin plus ticagrelor. At the 0 to 3 months after discharge, more than 80% of the patients still receive the aspirin plus ticagrelor. But after 9 months of this patient, you can see only around 30% of this patient still receive aspirin plus ticagrelor. Overall, more than 50% of the patient will receive de-escalation after discharge. So how about the de-escalation strategy we use in Taiwan right now? So again, you can see that here, the vertical axis here is the percentage of the patient. The horizontal axis here is the time after discharge. So you can see the brown color here is the patient that received the aspirin plus clopidogrel. So you can see most of the patient after discharge, the most commonly used de-escalation therapy is aspirin plus clopidogrel. The green color here is the P2Y12 inhibitor monotherapy, including the clopidogrel mono or ticagrelor monotherapy. So usually you can see that in the first 6 months after discharge, the aspirin plus clopidogrel and P2Y12 inhibitor monotherapy will be the 2 most popular de-escalation therapy currently in Taiwan in those patients originally treated with aspirin plus ticagrelor. So if you break down into look-see and see the use of P2Y12 inhibitor monotherapy, you can see here. At the first 3 months after discharge, if the doctor want to use P2Y12 inhibitor monotherapy, most the doctor will choose ticagrelor monotherapy. That is the red color here. You can see if the patient receive a de-escalation to the P2Y12 monotherapy at the first 3 months of discharge, most doctor will choose ticagrelor monotherapy. But around in 6 months after discharge, you can see the doctor choose clopidogrel mono versus ticagrelor mono will be almost similar. So that's the current condition we have right now in Taiwan. So we are interested that in those patients originally treated with aspirin plus ticagrelor, when the doctor want to choose the aspirin plus clopidogrel, the APSC, or they choose ticagrelor monotherapy, So what's the clinical factors that will determine which one will be chosen? And the clinical outcome for those who receive treatment with aspirin plus clopidogrel or those with the ticagrelor monotherapy. So you can see the analysis here, that is the clinical outcome here in those patients with acute myocardial infarction and multivessel disease. The clinical outcome, including the ischemic outcome or the bleeding outcome, you can see the two groups are almost similar. And the right table here is those patients with high bleeding risk that carry at least one HBR high bleeding risk factor. You can see that here. If you compare the treatment with aspirin plus clopidogrel versus ticagrelor monotherapy, the clinical outcome is almost the same. So ladies and gentlemen, let me make my final conclusion. Currently in Taiwan, the aspirin plus ticagrelor is the most commonly used DAP strategy for patients with acute myocardial infarction after PCI when they discharge. But for those patients with the aspirin plus ticagrelor, the de-escalation was very common after discharge. During the first 6 months after discharge, the aspirin plus clopidogrel and ticagrelor monotherapy were the most commonly used de-escalation strategy right now in Taiwan. And in our observational study, the clinical outcome was similar in those patients de-escalating to ticagrelor mono versus aspirin plus clopidogrel. However, the study still is an observation study, and the bias cannot be avoided in our study. Thank you very much for your kind attention.
Thank you very much, Professor Lee. And thank you very much for the excellent keynote lecture. We are going to discuss later, so let's move on to the young speakers session. The first speaker is Dr. Yasushi Ueki from Japan. He's going to present the ACS status in Japan. Thank you.
Hello everyone. So I'm Yasushi Ueki from Shinshu University Hospital, Nagano, Japan. I'm currently a leader of the young group of the JCS. So let me summarize first the basic information of ACS in Japan. So the patient age, mean age is 71 years old. I think this is a little bit older than the usual patient in Japan because so this data is from the Nagano. So Nagano is a little bit aged prefecture in Japan. And 77% are male. So regarding the percentage and number of ACS, so 40% of all patients are undergoing PCI ACS. And the number of STEMI and non-STEMI are currently increasing. So the current number is 63,000 patients. And in contrast, unstable angina pectoris patients are decreasing. I think this is very similar to other countries, I think, because this is probably due to the high adoption rate of the high sensitivity troponin. That's why we diagnose patients more as MI. And about the treatment option for ACS. So in Japan, most ACS patients are treated by emergent PCI with DS. So in Japan, so there are many hospitals that can perform primary PCI. So thrombolysis is quite rare in Japan. And about selection of antiplatelet therapy, so this is according to the JCS, so our DAPT guideline 2020. So if the patient has no high bleeding risk, so we treat patients with 3 to 12 months DAPT with aspirin and low-dose prasugrel. I think low-dose prasugrel is currently used in Japan and also Taiwan. So it's quite rare so for us to use ticagrelor due to the concern of the bleeding of a high risk, increased risk of bleeding. And if patient has a high bleeding risk, So we treat patients with short DAPT, 1 to 3 months DAPT, with aspirin and low dose prasugrel. And about the door-to-balloon time. So this is based on our national database, JPCI registry. This is a national database of PCI in Japan. And 73% of ACS patients achieved D2B time less than 90 minutes. So I think this is a good number. And of course, longer D2B time was associated with increased risk of mortality, as you can see this figure. So finally, I'd like to summarize the current problems of ACS in my country, Japan. So first, management of elderly patients. As I said before, Japan is a very aged country. There are many elderly patients. National data shows 29% of the 125 million population. This is a Japanese population. It's aged 65 or older in Japan. So how to manage very elderly patients and frail patients should be clearly defined. And diverse outcomes of STEM patients. Even in Japan, so in a rural area, the number of STEMI patients is smaller and mortality is relatively higher than urban area, which may be due to the potential delays in transfer and emergency systems. And finally, so we have currently facing a challenge of how to maintain our emergency care system. So due to the work system reform by Japanese government, this is due to, to reduce our working time to prevent us from, exhausting too much work burden. Some areas in Japan will face a difficulty to maintain the emergency care system. So these are the current problems of ACS in my country. So that's it for my presentation. Thank you very much.
Thank you very much, Dr. Ueki. He nicely presented the current status and problems of ACS in Japan based on the JPCI registry. Thank you very much. The next speaker is Yeonjun Lee from Korea. He's going to speak about the ACS status in Korea. Okay.
Thank you very much, sir. Good afternoon, ladies and gentlemen. My name is Yeonjun Lee from South Korea. First of all, thank you very much for inviting me to this great meeting, JCS 2025. And today I'm going to talk about the acute coronary syndrome in Korea. I have nothing to disclose. So first of all, I'm going to talk about the basic information of ACS in Korea. As you can see in this figure, the annual incidence, the ST elevation myocardial infarction has decreased. However, for the non-ST elevation myocardial infarction, the rate of it has been increasing. And for the symptom onset to balloon time, as you can see in this figure, it has been decreasing. I think this is probably due to thanks to the development of the medical technology, and as well as our efforts for educating the patient or the general population that you have to come to the hospital when you have the chest pain. And next, and for the antiplatelet therapy after ACS, especially for the P2Y12 inhibitors, as you can see in this figure, the use of clopidogrel has been decreasing. However, the usage of the potent P2Y12 inhibitor has been increasing. I know that there has been a great RCTs done by the Japanese group, such as the STOP-DOC trial. However, in Korea, the most patient took ticagrelor instead of the prasugrel. And for the in-hospital mortality and MACE, the rate has been decreasing until 2011. However, after 2012, the rate has been kind of plateaued. And as I told you before, a lot of patients were taking ticagrelor after ACS who underwent PCI, and there has been a great interest especially for the Korean population, about evaluating the impact of the de-escalating antiplatelet therapy, especially using the ticagrelor. And the TICO and TPES trials are the important trials done in our country. And last summer, I had this chance to merge the data of the TICO and TPES trials. And TICO trial is the first trial which evaluated the ticagrelor monotherapy after 3 months stop. And the TPES trial is the consequent trial which evaluated the ticagrelor monotherapy after less than 1 month stop. And last summer, I have this chance to merge the data of the TICO and TPES trial. And what we have found was that the rate of the major ischemic outcomes defined as the all-cause death, MI, and stroke, which this was not different between the standard DOP and the ticagrelor monotherapy after short-term DOP. However, for the major bleeding, defined as the BARC type 3 or 5 bleeding, the rate were significantly lower in patients who took the ticagrelor monotherapy. And this ticagrelor monotherapy strategy has not been well, not only for the Asian population, this is kind of interest worldwide. And representatively, there has been a larger IPD meta-analysis published in Lancet. But what we have to focus is that among the 6 trials included, the 4 trials were all from the Asia. So early this year, I had this chance to collaborate with the Chinese Nanjing group. So I have to merge the data, not only the TICO and TPES, but thanks to the Chinese Nanjing group, they have provided us the data of the ultimate type trials, and I were able to merge the valuable randomized data of the 9,130 patients of ACS. The results were consistent with the previous reports of European Heart Journal, but what we have additionally found was that the results were consistent or respect of the type of the ACS, including STEMI, unSTEMI, non-STEMI, and unstable angina. I think this is probably possible because we had this large data set. So this is the end of my talk, and I really look forward for the future collaborative research with the Asian investigators. Thank you.
Thank you very much, Dr. Lee. He kindly presented us the most recent evidences from his institute in Korea. Thank you very much. The next speaker is Dr. Tinakrit Samplaha from Thailand. Thank you.
Okay, thank you for your kind introduction. I'm Tinakrit Samplaha from Rama Thibodi Hospital, Bangkok, Thailand. Today, I'm really proud to present my presentation about Thailand perspective about Acute Coronary Syndrome. I have nothing to disclose here. In the last year, in our country, we have about 72 million people, and the cases of ACS is about 25,000 cases a year. And 2/3 of the cases are male, and the mean age is quite lower than in Japan and in Korea, about 67 years old. Half of them are STEMI. But the in-hospital mortality rate is still high in my country. It's about 9% for STEMI and 5.8% in NSTEMI. Interestingly, for STEMI patient, we still use some thrombolysis, about 16% of the cases, and only 70% of the cases have reperfusion therapy, and 30% did not receive any reperfusion. We did a good job to give the patient aspirin and statin over 90%. But for P2Y inhibitor that we have discussed, in our country, we use mostly clopidogrel, about 82%, only 18% for ticagrelor and prasugrel. So there's a big room of improvement, I think. What about current issues that we have to take into this consideration? I think for my country, first thing is time. Start with the symptom onset to first medical contact for the patient is quite delayed, 2 hours. So I think we need more educational program for the patient to let them know when to go to the hospital and need more better transportation to take them to the hospital. And not only that, the first medical contact time to PCI or lytic therapy is quite delayed, not medical. About more than almost 2 hours for primary PCI and 30 minutes for femorolysis. I think we lack of cath lab and lack of staff in the rural area. So that's why this number is quite delayed. So I think the big room of improvement too. And for STEMI or non-STEMI patient, we still most use of transfemoral, which the guidelines say we should use radio with reduced mortality. I think we have to do more transradial. And not only we still use lytic therapy, most of them we use streptokinase because of the budget. And for a secondary prevention, only a quarter of cases can meet LDL lower than 70, not to mention 55, forget about it. I think just 70, we can reach only 25% of the cases, quite low, I think. And I think we now in the Southeast Asia, have been facing with a new problem in the last 5 years. It's a PM 2.5, which we know that links to the coronary heart disease. I think that's a major problem now. If you go to Bangkok now and you will see a brown fog in the morning, believe me, it's not a fog because it's really hot now. Right? Okay. And the bright side of our country is all these things are fully reimbursed. If you have a heart attack and you are Thai and you go into a private hospital in Thailand, you have been done the PCI without any payment. The government will pay for you. Thank you for your attention.
Thank you very much for a very interesting presentation, Dr. Shamplahat. Thank you. The next chair is going to Professor Lee.
So the next speaker will be Dr. Kaushik Manna from India. Dr. Manna, please go ahead.
Good afternoon, respected chairperson, sir, and esteemed panelists. I feel proud and privileged to be present here and present my country, ACS in India, current status. I currently working in RNT Hospital, Kolkata, India, and I have nothing to disclose regarding this financial conflict. So as you can see from this slide, the global burden disease study showed that almost 1.2 million patients are suffering from ACS in India currently, and majority of them are young, less than 64 years of age, and among them less than 30 years, from 18 to 30 years age is almost 7%. So the age is decreasing and the incidence of ACS is increasing, and majority of the they are living in the metropolitan cities. And when we search the other risk factors, among other than the standard risk factors, major risk factors, there are some emerging risk factors we faced, like smokeless tobacco use, binge drinking of alcohol use, Indian specific dietary factors, is oxidized fat, food pollutants, preservatives, indoor air pollutions, high TG content food, lipoprotein small a, and many more. If we see the diversity in our country, we can say that smoking has decreased throughout the country. But the other risk factors, that's overweight, diabetes, and hypertension, they are increasing, especially in poor areas and with low educational areas. That is a challenge for us because we don't have nationwide registry data till now, because just because of the diversity and some other political reasons. So we have to work on it, and CSI is working on it. And if we see the clustering, there are variation of clustering. Even within a family, there are cluster difference if we consider the risk factors as a whole. So regarding the management strategy, we go by the ACC guideline. We use DAPT therapy for first 1 year in ACS patients, and most of the cases before 2022, clopidogrel was used almost 60% cases, but now ticagrelor is on upfront. We are using ticagrelor with aspirin combination in ACS patients mainly. And regarding the other drugs, we use standard guideline-based therapy for the rest of the patients. But the most difficult thing is that the reach of the patient, only less than 3% of the population, patients suffering from ACS, they could avail the primary PCI strategy. So India is lacking to meet all the unmet needs. So we come with hub and spoke model. Recently it was in the pilot project already started in Goa, Tamil Nadu and Kerala, and with a good result. Access to pharmacoinvasive therapy increases from 3% to 30% with a drop in 1 year mortality of 19%. And having cost-benefit ratio, in this model, we utilize government sources and private hospital with the artificial intelligence in between. Any patient suffering from ACS or chest pain, they will do the ECG. The ECG will be interpreted by the team of this particular model, and the patient will be transferred to the nearest hospital, whichever is nearby, less than 30 minutes. If it is a PCI capable hospital, he will go for primary PCI. If it is not PCI capable hospital, you will go for thrombolysis, and then they transfer the patient to the PCI capable center. So every patient, we make sure they get some sort of pharmacological or primary PCI therapy. And above all, I can say that the short-term mortality is still high compared to the other class 1, European countries and American countries, and obviously in Japan also. We are lacking. We are still there is high STEMI mortality in STEMI as well as in STEMI. What we are lacking is the socio-economic inequality, lower education level, and less access to the basic therapeutic needs for ACS patients. We are still lacking in this area. So with the help of this government, the public hospitals and the CSI, they're trying to solve this problem out. Thank you.
Thank you very much. So the next speaker will be Dr. Shakaya from Nepal. Go ahead, please. You have 3 minutes.
Thank you. I'm Dr. Smriti Shakya. I'm from Nepal. I work in a government hospital, which is a tertiary care center hospital, Monmon Center, which lies in the capital city, capital of Nepal. So to begin, and I'm very much thankful for this platform to present about ACS in my country, Nepal. As ACS is growing everywhere globally, it is also a growing public health challenge in our country. And as ACS is growing, there is a lot of challenges, additional challenges that we have. The first and foremost is the rising prevalence of cardiovascular risk factors as other part of the world. But there is limited healthcare access in remote areas in our country. This is a map of Nepal, and here we can see different healthcare centers, health posts, and different levels of hospitals. But most of the hospitals are located in the capital, Kathmandu. So we still don't have a national registry of how many ACS cases are there in Nepal overall, but there are segregated, there are different studies done in different parts of the country. So overall scenario in Nepal is cardiovascular diseases. It is responsible for 26.9% of all deaths in Nepal. And ischemic heart disease contributes to 16.4% of total deaths. And the incidence and mortality rates has increased from 1990 to 2017, and more it is seen in males and more in older age group. So the leading risk factors seen in my country for ACS are smoking, hypertension, diabetes, high LDL cholesterol level, air pollution, a diet low in whole grains and fruits, and physical inactivity, which is mostly seen in urban area, whereas in urban and rural areas, the use of tobacco is the prime cause. So in my country, so different studies were done in the eastern part, western part, central part, and I'm just averaging. Whenever in the central where there is capital, so the problem might not be that obvious, but those who are in the periphery, and who are a lot of them, they have problem. So most of them they are late presenters. So, and in periphery, since there are not much PCI centers, they opt for thrombolysis, and the main drug used for thrombolysis is streptokinase because it is cheaper. And so there are variable in-hospital mortalities, 15 to 20% in different areas. So in my center also different studies are done, and whenever the patient comes, we first of all offer them primary PCI, and if they are not affordable, then they undergo thrombolysis. A study was done among young patients as well in my center, and where we see that 3/4 are male patients, and 3/4 had ST elevation MI. The most common cause was smoking, and the most common finding was single vessel disease. At another center, which is also a national heart center located in Kathmandu, they have started doing registry in their center. So they collected around 1,460 patients, and the mean age of them was 60 plus minus 13 years. Among all, 83.2% of the patients were referred cases. And about 82.1% underwent coronary angiogram. However, only 31% received reperfusion therapy in the form of primary PCI and fibrinolysis. The reason being that most of them were late presenters and primary PCI was not feasible, so they had some kind of elective PCI. And in-hospital mortality was 6.2%. So we have different challenges in our country. The first thing is the delayed presentation. That could be because of lack of awareness about the ACS symptoms, thinking them to be APD symptoms, and lack of awareness about the importance of timely medical intervention. There is accessibility issues because of the topography and the financial causes and the delayed diagnosis as well. And the prime important challenge is that there are limited availability of the PCI centers outside the capital. Whereas in case of secondary prevention of ACS, many of them get aspirin, clopidogrel, statins, and in our center, we also prefer ticagrelor and prasugrel. So this is an overall problem we see in my country. A person needs to reach from the topmost of the right, somewhere from there, and then they reach in our center. So by the time they have to travel through different hurdles, like the roadways, difficult roadways, and then finally they land up in our cath lab. Thank you.
Thank you very much, Dr. Shakya. So the next speaker will be Dr. Kumar from Pakistan. Dr. Kumar, go ahead.
Thank you for the introduction, and I'm again thankful to the JCS and to arrange or invite the Pakistan to represent here. What is the status of ACS in Pakistan? I have no conflict of interest. Pakistan being the 5th most populous nation or in the region or say in the world, we can see it here in Pakistan. We have the largest healthcare network where I'm working with it. It's an NICBD, but unfortunately this healthcare network is localized to the one province only, that we can't find such type of network throughout the country. So what is the incidence overall? We have seen that global burden of diseases estimates that the incidence of ischemic heart disease in Pakistan is 673 patients per 100,000, and the death rate is 183, which is quite alarming. What the characteristic that we see in Pakistan that are young patients, you can see that here, at less than 40 years, approximate more than 1/3 of the patients who present with the ischemic heart disease in our chest pain units in our network, they are less than 40 years of age. And also, it is increasing the female patients. Approximately more than 1/3 of the patients, they are female. So that's, again, different. What the cath lab data we have seen in our registries in Pakistan, that those who have premature coronary artery disease, they have higher number of the female patients, there are increased number of smokers, and definitely there's high risk of the family history. So we can see here, and treatment that we get or the patients are getting, those patients who reach to the cath lab, majority of them go to the angiography, while half of them do go for the angioplasty because of the cost constraints. While looking at the secondary prevention of the diseases, you can see that aspirin and P2 or DAPT, 71% of the patients, they are getting DAPT after the coronary angioplasty. While looking at the cardiac rehabilitation, I think this is a very much important that we must be emphasizing the primary prevention. So the secondary prevention, cardiac rehabilitation is very much poor. Only 50% of the patients, they are getting the cardiac rehabilitation. So what are the issues that we are facing in our country that I have summarized in the single chart? That because of the higher cost, we being a developing country, low socioeconomic or low income country, we have majority of the people, they don't access to the hospital because of the higher cost. Difficult access because majority of they are living in the rural areas, not in the urban areas. And because of the living in the rural areas, they are delay in the diagnosis. So less number of the people reach to the country or led to the tertiary care hospitals. Limited availability and drug compliance definitely is a big issue because of the cost again. And thank you. And third, last one, Dori, we don't have national database so that we can represent the whole country. The data that I've showed is the different areas that I have picked from different areas of the province. Thank you.
Thank you, Dr. Kumar. And the last speaker will be Dr. Prasanna from Sri Lanka. Please go ahead.
Good evening. Thank you, Chairperson, sir. At the outset, I would like to thank JCS for inviting for this session. So I'm Dr. Ajit Waniarachi from Sri Lanka, consultant cardiologist and secretary of Sri Lanka Heart Association. So you can see our country, which is where it is located in Indian Ocean, just separated from India. So I have no conflict of interest. So if you look at the statistics for our country, so you can see these statistics are not based on actually registry. We don't have a registry yet in our country. However, from the Ministry of Health, who is responsible to collect data for all the diseases, that is where from I took this data. So when it comes to ST elevation MI, over around 90,000 cases were reported for last year. There were a lot of cases with non-ST elevation MI together with unstable angina and chest pain, accounted for close to 40,000 cases. And we see patients with younger patients affecting, and also young males getting more ischemic heart disease. When it comes to treatment, there are 3 modalities actually for the acute coronary syndrome, especially for ST elevation myocardial infarction. So still we depend on thrombolysis. We were using tenecteplase 100%. However, during last few years, we were not able to use tenecteplase alone. We have to import streptokinase because of economic constraints. So about 80% of patients receive thrombolysis. Most of the hospitals all over the country are distributed with thrombolytic agent. When it comes to primary PCI centers are minimum. However, the numbers are growing. We have about 10 cath lab centers. Basically, we can divide our health service into public and private. Public, we have 10 cath centers, and private, we have around 9 cath lab centers. So out of them, about 2 to 3 cath lab centers run 24-hour primary PCI program. When it comes to cardiothoracic centers, we have only 4 cardiothoracic centers for entire country. However, we have about 8 private hospitals giving this service. When we talk about secondary prevention, antiplatelet therapy and statins are provided free of charge for all patients in our public hospitals. However, the expensive drugs like ticagrelor or prasugrel are not provided. They have to, patient has to buy it from their own. So let me go through what are the challenges we face when it comes to acute coronary syndrome. We had a huge problem of lack of tenecteplase last few years, but we have re-established the service, and therefore we had to depend on streptokinase, which was a low-cost drug. And when it comes to cath lab centers, there's a huge maldistribution in the country because mainly the cath lab centers are not distributed according to the population density, and certain areas are not covered well. The available cath labs has also problems. The number of stents and the hardware supply is not adequate to meet the demand. And also we are facing huge challenge with the health staff, especially cardiologists. We have only around 100 to 150 cardiologists working in the entire country. And also the supportive staff are also less because most of these people start migrating last couple of years. We do see increase in number of cases of acute coronary syndrome in our country, and also atypical presentations of acute coronary syndrome, and also younger patients, and late presentations are also a huge challenge. The risk factors like diabetes, hypertension, and CKD, prevalence is also growing. These are adding to the current scenario as a challenge to the management of acute coronary syndrome. The other most important thing I would like to highlight, we don't have established database like other presenters showed. However, we are trying to establish new database for the acute coronary syndrome patients with the college and with the support of the Ministry of Health. Probably we will be able to develop it very soon and implement very soon. So thank you very much for listening.
Thank you very much. So we'd like to start a discussion session, and we'd like to welcome Professor Human Ban Min from Vietnam and Professor Lana Mani Gajulel from Nepal, and also Professor Sampas Winsawam Sam from Sri Lanka. Please come up to the stage, please. Thank you. So first, I'd like to accept any comments or questions from the audience. Is there any question? Okay, so let's start the issue of the anti-platelet strategy for the ACS. So the anti-platelet strategy is quite different among the Asian countries. So I'd like to ask each president for their thought regarding the DAPT after ACS. So could you give us some comments from Professor Min, please?
Hello. Dear Chairperson, dear colleagues, and dear audience, congratulations and the speaker. I think this is very important information for us, especially in Asia countries. First of all, I would like to share some my own opinion about the presentation. There are the three areas very important for acute coronary syndrome in our area. The first one is the primary prevention. I think the very important sectors. That is how to control the conventional coronary risk factor, such as hypertension, the diabetes mellitus, and hyperlipidemia. And besides these conventional risk factor, we must concentrate and pay attention to others non-conventional. For example, the pollution, air pollution, and climate change. Very important as the Thailand presentation. And the second areas, I think, very important also. And unfortunately, there is some diversity. That's either the intervention and medical intervention and PCI. That's either in the hospital. The first, that's either most of the presentation we still use the fibrolysis with septokinase. And I don't know how about this, but recently we replaced in our country, we are tendency to replace septokinase readily by actylase, retripiase. We can shorten the time for perfusion, and especially they reduce the risk of bleeding. And secondary, we apply how about the PCI in our hospital? For example, how to shorten the door to balloon and door to door, very important. That's how to move the patient to the PCI center, because there is many countries, many regions, we are in remote area. We are lacking to have a suitable mean transportation the patient. And I see some presentation, we have applied the helicopter, very model, but this is too sophisticated. And that's open up how to create, how to develop the many PCI center in whole country. For example, in our country, Vietnam, there is a very long country, S-shape, from to north to south, about over 1,000 kilometers from from Hanoi to Ho Chi Minh City. So we must develop so many PCI center. Recently, we have at least 100, more than 100 centers. And secondly, that's either you have described many drugs to you, especially the combined DAP or single SAP, for example. And the most popular, I think we apply also the aspirin and clopidogrel. And how to set that, because this is a dual antiplatelet therapy is less expensive, more popular, and at least we have many experience with this combination. But as others guidelines in the world now, especially in the Europe and USA, we are tendency to increase the combination between the aspirin with the ticagrelor. Very important, because following the many studies, my trials, RCT, it showed that this combination can reduce the restenosis and maybe less bleeding with the others patient. And I think the most important combination, we must base upon high risk and low risk and middle risk of the patient. And we must balance between the hemorrhage and thrombosis. And I didn't see why the presentation of the speaker then describe which are the risk score applied for your study. For example, we can use for example, high splat, atrial gap-fill, for example, and others, for example, Syntac, to apply for the patient, and which is the most popular and most suitable risk score for bleeding, for thrombosis, for Asian patient. I think in the future we must describe to have a good decision when we use the short-term, long-term descalation, reduce the dose of the dual antiplatelet therapy. Very important. And in your presentation, I did see also the how many patients we must move to the surgical therapy. For example, bypass therapy, because we have many patients with, especially with ST elevation, myocardial elevation. We must ask the intervention of the cardiac surgeon to have a emergency bypass, CBG, very important also. And maybe we have a cardiogenic shock. In that case, we must have a discussion with the cardiac surgeon. And I think the presentation we can discuss profoundly about in the special case. And one of the most important that is for the very old elderly person. I'm very interested of this special population. Most of the patient now become older and older. We have many patients over 18 years old also. But most of the patients, that's either no decision of the interventionist, but this is a decision of the patient, and maybe they have family, they refuse to be intervened. Yeah, normally the patient refuses. They choose the medical treatment better. So I think how to resolve it is a big problem. Maybe our colleague will have some comment. And finally, very short, that is secondary prevention, very important also for the patient when they discharge from the hospital. In the how to prevent the risk factors. Maybe we have some relapsing. Maybe they must expect to have another intervention. And so I think we can have a certain very strict measure, recommendation for the patient when they discharge from the hospital. And finally, to resolve this problem, I think one of the most important, that's the policy of the Ministry of Health, how they apply the insurance, for example, social insurance. Vietnam, 90% of the population can have the insurance. They will pay, but not 100% of the price in the hospital, but only, for example, I see for example, an ICD, they pay only 1/10 of this price. And for intervention, the first time they pay only 1/10. And the others, their family, the patient, will pay themselves. That's all. Thank you.
Okay, so please give us some comments for Dr. Risa Basam.
Thank you very much. Thank you very much, first of all, JCS, giving this opportunity, and this collaborative session would give the regional countries increase the collaboration among us. So I think Professor has given a comprehensive lecture on the problems in the region. So I'll speak to much more relevant to our country and the region. So first of all, I think we have a problem because most of us depend on Western data on treating ACS, and the guidelines also based on mainly their figures. But we have fundamentally, probably genetically different. So we might have slightly different risk factors, risk categories, and even what the correct LDL, the levels, what's the actually which level that we have to achieve, still a problem. So again, we have even within the region, the South Asian regions, say Sri Lanka, Pakistan, Bhutan, and India, whether we are slightly different genetically. Again, it's an issue for us. So that we have to develop our own data, especially when we are calculating risk in treating. That is one of the things that I think APSC has to think about, and we have to have our own guideline, own data, own risk model to treat our patients. Then again, even though the guideline is there, we know that primary PCI is gold standard. We know that in Japan, in Korea, 99% probably the first or the choice of treatment is primary PCI for STEMIs. But when it comes to Sri Lanka, it's extremely difficult because of the economical issues. In ours, as we highlighted, 80% of the cases are being treated with the thrombolytics. But now, at present, most of, or probably more than 90% of these cases are being given tenecteplase. That is a better choice. Actually, in Sri Lanka, the price of tenecteplase is 30 times higher than streptokinase. So big cost difference is there between two. But given the end results, the tenecteplase is cost effective economically. At the end, at the final say, tenecteplase is better. So we are concentrating to treat 100% with tenecteplase in case of the thrombolysis. And we are much more thinking about facilitated PCI and the rescue PCI in near future than try to attempt 100% primary PCI, which is, I think, probably not possible within next decade in Sri Lanka. But it's fastly developing. And then again, the manpower is a huge problem. I think not only for Sri Lanka, for the region. And out of that, the brain drain is the huge problem that we are facing. Most of the cardiologists, most of the other professionals, most of the allied health professionals are leaving the country, especially to the for the Western countries. So that's another problem that we have to look after within the region. I know that these problems are not very much relevant to the Japan, Korea, and so on, but it's very much relevant to us. And we have to think about these things within the region when we are developing our policies and so on. The positive thing in Sri Lanka, we are free in the healthcare, primary to secondary to tertiary, irrespective of age, from 0 to until they die. 100% free treatment anybody can get from the government hospitals. So that's a good thing. And because of that, Sri Lankan figures, health figures, are in par with most of the developed countries. If you see the look at the regional data, we are in par with most of the Western countries and the developed countries. With the figures is because the free education and the free health care, which is, I think, not available in most of the region. So that's a positive thing. I think we have to go a long way. We have to develop our system and to reach to other developed countries. But we are challenging, we are having a lot of challenges economically, but should be able to tackle when time comes within next decades or so. Thank you very much for giving this opportunity.
Thank you very much. Thank you. Our time is almost up, so Professor Gajul, could you give us some short comment, please?
Thank you, Chairperson. Respected President from different society, young cardiologists, and the delegates. I feel honored to be here as the President of Society, Cardiac Society of Nepal. Regarding the management of acute coronary syndrome in Nepal, we are among the countries like Nepal, India, Pakistan, Bangladesh, Sri Lanka, we are running through the same situation, I think. Particularly when we talk about Nepal, my colleague Dr. Saki has already presented on her slides that the Nepal is geographically very difficult terrain country because we have three geographical areas like the high Himalayas and the hilly areas and the Terai. So in the management of acute coronary syndrome, that is possible in the metropolitan city and the Tarai plain area. But it is very difficult to get the patient during the stipulated golden hours because of our terrain. In the hilly areas and in the mountainous area, the people are living very sporadically. They are not living in a cluster. So getting health services to these people are very difficult. So my friend clearly showed when the patient had acute coronary syndrome, the transportation is very difficult. Remote transportation is very difficult. Even if they get buses or something like that, the roads are not good. The nearest center to reach for the treatment, it takes 1 or 2 days. Not hours, not minutes. It's 1 or 2 days. It's the earliest one. So Nepal is different than the other country. Regarding what we are doing and what our government is doing to these people who are staying in the remote area, in the urban areas, in the metropolis city, most of the patients, they go to the hospital, they get treatment within the window period. Those who are financially backwards, they are getting support from the government. So the first primary PCI is the first choice in our country because the government has given a certain amount of money. Those who are really not able to pay for their treatment, that is the scheme. So we are giving some support. So most of the time we give the patient choice of primary PCI. If they deny or refuse, then at that time if they are in the window period, the thrombolytic period, we will give thrombolysis. And later on we do we do facilitate PCI or rescue PCI, it's like that. And we have another program. One of our province has this hub and spoke model. It's similar to the model in India, in Tamil Nadu and something like that, Goa. There are some PCI capable hospital, and there are hospital where the physician is available but PCI is not available. In that PCI is not available hospital where physician is available, if the patient come there, they will do thrombolysis with tenic triplets and they refer the patient to nearby PCI capable center. That is this hub and spoke model. So all the hospital is not the hub hospital. Those hospital which are recognized as a PCI capable hospital are considered as the hub hospital, and the PCI incapable hospital are considered as the spoke hospital. And the doctors, even the medical officer, they do ECG over there and send in the Viva group, and the consultant over there will see the ECG and advise by thrombolysis. It's like that. And other thing, most of the management of the acute coronary is similar to the country in our part of the world. Thank you. Thank you all.
Okay, thank you very much. So I'd like to close the first session regarding the ACS. I'd like to thank all speakers and discussers for the meaningful discussion. Thank you very much.
Then let's move to section 2, AF in APSC. My name is Ikko Nakano from Hiroshima University, and I will be chairing this part with Professor Seok-Min Kang from Yosei University. The first speaker is EP specialist, Dr. Corinio from Changi General Hospital in Singapore. The title of his keynote lecture is Upgrading the Care of Patients with Atrial Fibrillation in Singapore. Dr. Yo, please begin.
Thank you very much, Chairpersons. I'd like to thank the JCS for inviting me to give this session today. So I'd like to take the chance to share what is happening with AFib management in Singapore, and I hope to get to interact with all of you from this session. These are my disclosures. So I'm going to briefly run through from lifestyle interventions to primary care to allied health care and before we go to specialty care. Because I think ultimately the best treatment is to have no disease. Now, atrial fibrillation is the most common arrhythmia in the general population, and Singapore is trying to catch up with Japan and Korea in being an aged population due to our declining birth rates. So we are aging quite rapidly. So about 5.8% of our patients above 80 years old were found to have AFib, and 20% of the patients who come to our stroke unit were found to have AFib. And many of them don't know they have AFib. Now, Singapore is a unique Southeast Asian country compared to many Asia-Pacific countries because we are quite heterogeneous. So about 73% of our population is Chinese, and about 14% of our patients or people are Malays, which is the indigenous population, which is similar to our neighbors, Malaysia and Indonesia. And about 9% of our population will be South Asians, predominantly from Tamil Nadu. And you can see that what makes research in Singapore so interesting because we can look at how the disease and the treatment differ from ethnicity to ethnicity. So in green here we have the Malays, which are the smaller proportion in population, and yet they have a higher incidence of atrial fibrillation compared to the larger population, the Chinese, represented in blue, and then followed by the Indians. Now, we know that there are risk factors to developing atrial fibrillation, and the many ones will include obesity, sedentary lifestyle. These are risk factors, and we know that moderate intensity exercise will also help to protect you against atrial fibrillation. So one of the incentives that the Ministry of Health in Singapore, together with the Health Promotion Board in Singapore, is to gamify active lifestyle. So we actually distribute these trackers, which you can get it for vending machines for free. Or if you own a watch that has a pedometer who can track your sleep, for example, so you can download this app for free. And every day, if you can clock at least 5,000 steps a day, get at least 30 minutes of moderate intensity exercise, and now more recently, if you can sleep at least 5 hours a day, you get points for it every day. And this is a screenshot from my own mobile phone. So you can see that I'm accumulating 2,000 over points for this short period of time. And you can collect vouchers. So you convert these points into vouchers, and you can use it for grocery shopping and other things you like. So that's a very popular thing that some of the general population, not just patients, general population are trying to achieve. Then primary health care is a cornerstone to our treatment in any healthcare system. Now in Singapore, we are also a bit different in some reimbursement systems in Asia Pacific. We have a mixture between public and private. So in the public primary care, they are known as the polyclinics, and they are a significant proportion of patients who go there for their primary health care. And so several years now, we've introduced a routine ECG screening for the asymptomatic patients who just come in for their chronic disease management. So this helps to pick up asymptomatic atrial fibrillation, and that increases my workload because I get to see some of them now. Now, anticoagulants is the cornerstone in thromboprophylaxis, and the DOACs is the recommended choice of anticoagulants. So I'm also thankful that the Ministry of Health in Singapore has really dropped the price, or forced the vendors to drop the price to make it very accessible for the masses. Again, mainly for the public polyclinics. And we also make it available for specialty services in the polyclinics. So if the doctors in the polyclinic want to order echocardiography, Holter, for example, they don't have to send the patients to the hospital and jam up the system. They can refer these services, we analyze them, and we send the results back to the patients. And then, of course, the doctors can make the decision whether they can just manage them in the primary care or they need to refer to the hospital. Now, this year is also the first year that Singapore has started this program called the Health DSG. So the private GPs or general practitioners are also not forgotten. So we try to match-make the patients to their favorite GPs. This is mainly to prevent them from doctor hopping. So the doctors will then formalize a personalized healthcare plan. If you have chronic disease, then we try to manage it. If you have no chronic disease, then obviously we try to encourage you to exercise, lose weight, and basically upstream therapy. Then now we move on to specialist care, and I think this is not unusual in North America and Australia, but I think for Asia Pacific countries, this concept of a nurse clinician is probably still not quite in vogue. So for several years now, we have identified certain senior nurses who have leadership potential and who have interest to pursue this clinician track. So they take up this nursing clinician track. So they are functioning like junior doctors. So they are trained to make clinical diagnosis, do physical examination, and importantly, also prescribe medication. So knowing the indications and side effects of the medications. So of course, we have this AFib clinic that is led by a nurse clinician, and this was started a few years ago in March 2021. We allow the nurse, in this case, to be able to manage some of the AFib patients. So this AFib clinic specifically looks for the trickier patients, those who need rhythm control or they have difficulty doing rhythm control, for instance. So they actually sit in an adjacent clinic to the EP doctors so that they're also given support. Should they run into difficulties, they can just hop in and get our second opinion. So you can see that over the months since it was started up, the charts have been going up. And why so? Because they help to take up the excess patients that we really couldn't cope. So on the left side, you see the blue bar was before AFib nurse-led clinic was started. You can see the green bar was the overbooking, which means the extra patients were forced into our clinics because we have only so many slots. So shortly after 2 months, after 12 months after starting the nurse-led AFib clinic, you can see that our throughput has improved and our overbooking has really plummeted. So really trying to ensure that the more complex patients get the necessary medical care. And of course, we need to partner our general cardiologists. And you know that AFib is evolving significantly, especially the last 5 to 10 years. So we help to keep them up to date with some of the data, and that really increased our referral rate. Not that we need to increase the referral rate, but at least refer the ones that really, really need to. So for example, rhythm control in HFrEF and HFpEF have really showed quite a lot of benefits in the last few years now, and we do get a lot of referrals for that. And it also get updated with the new energy source, the pulse field ablation, which really helped to drop our procedure time. And now they are also more aware, and they can help to preempt the patients when they refer the patients to us. And also, we have this separate device arrhythmia clinic that sets parallel to heart failure clinic. As you know, heart failure patients have a higher risk of developing AFib, and that's how they can also get cross-referred to us when their heart failure patients run into trouble. We also collaborate quite a lot with our neurologists, so we work with them to update them that we have extra services, not just the usual 24-hour Holter. We can offer extended ECG services, and of course, the role of implantable loop recorders to really pick up those occult AFib that may be missed with necrotogenic stroke patients. And we also partner them to participate in the trials. For example, the recently concluded Oceanic AF trial. So we were part of it to really evaluate the role of novel anti-11A inhibitors in stroke prevention. And of course, when it comes to the subspecialty will be the EP guys. I think I'm glad that the Ministry of Health in Singapore was willing to subsidize. So Singapore's healthcare system is also unique. We don't fully reimburse. In the public healthcare system, it's a subsidy system based on your actual income. And so pulse field ablation was introduced in Singapore in September 2022. It is more expensive than radiofrequency energy and more expensive than cryoablation. But nevertheless, I'm thankful that this new energy source is also made available to the public healthcare quite quickly when it was launched in Singapore, so that we can improve our throughput, reduce procedure time as demonstrated in multiple studies in PFA, and potentially safer than the gold standard of RFA. So in summary, I think I've tried to give you a little bit of a multi-pronged approach, consolidated view of how we try to reduce AFib complications and incidents in Singapore, despite our aging population. So I think it's really multi-pronged. We need to really involve all stakeholders, the patients themselves, the primary care, our allied healthcare workers, and also raising awareness on the availability, risk factors, and the treatment modalities for our patients with atrial fibrillation. So with this, I thank you very much for your attention, and we'll be glad to learn from everyone. Thank you.
Thank you, Dr. Yo. Then we will begin the presentations by the 6 young speakers. Each presentation will be about 3 minutes long. There will be no Q&A time for each presentation, and the discussion will follow all presentations. The first speaker is Dr. Yuko Matsui from Japan. Please begin.
Thank you, Chairperson. Good afternoon, everyone. I'm Yuko Matsui from Japan. I'm honored to have the opportunity to speak here. Today, I'd like to talk about the current AF management in Japan. I have no COI to disclosure. Let's start with the basics. Japan has a population of 120 million, and over 700,000 people have AF. That gives us a prevalence of 0.56%. As you know, Japan is an aging society, and that trend is reflected in our AF patients. Their average age is 74, with 92% over 60 and 31% over 80. Compared to Western populations, Japanese AF patients tend to have lower body weight, more comorbidities, and a higher stroke risk. Over the last 10 years, we've seen a steady increase in anticoagulant use in Japan. The higher the CHA2 score, the more likely patients are to be on anticoagulants. There has been a major shift from warfarin to DOACs, which are now widely prescribed. And AF ablation is actively performed in Japan. The Japanese guidelines now recommend ablation as a first-line treatment for paroxysmal AF and AF complicated by heart failure, including AF-induced cardiomyopathy, HFrEF, and HFpEF. The number of procedures has been rising here, with 68,000 AF ablations performed in 2022 alone. Japanese guidelines also emphasize aggressive risk factor management. Comorbidities like hypertension, diabetes, and sleep apnea are actively treated. Patients are also encouraged to modify their lifestyle, focusing on weight control, smoking cessation, and reducing alcohol intake. Despite these advancements, we still face major challenges in AF management. First, Japan is aging fast. Right now, 29% of the population is over 65. But by 2050, that number will reach 38%. With this, AF prevalence is projected to double to 1.09%. Second, a growing elderly population combined with advancing medical technology is driving healthcare costs higher than ever. Thank you for your attention. I hope this presentation triggers some good discussion. Thank you very much.
Thank you for your presentation. The second speaker is Dr. Wei-Tin Liu from Taiwan. Please begin.
Thank you for the introduction. And it's my privilege here to introduce the AF management in Taiwan. I'm Wei-Tin Liu from Tri-Service General Hospital. I have no conflicts of interest. And the prevalence of atrial fibrillation in Taiwan is about 1.8% in general population. And the prevalence increased to 5 to 6% at a patient age 70 or older. And atrial fibrillation patients are aged about 71 years old, and the average TRAVA score is 4.1. Atrial fibrillation patients had more comorbidities and higher adverse events. And using National Health Insurance database, we found that 80% of atrial patients had only rate control agent within the first year. About only 20% of the patients received recent control within the first year. And for catheter ablation, the radiofrequency ablation is most widely used, followed by cryoballoon ablation, which is partially reimbursed in 2017. And we just had a pulse-field ablation last year, and it's not reimbursed yet. For surgical ablation, concomitant surgical ablation is used in about 28% in the patient undergoing cardiac surgery, and the rate increased in recent years. And the NOAC introduction, which include increased prescription of oral anticoagulant for OAF patients. And for now, most of the patients receiving oral anticoagulant are using DOACs. And safety and efficacy of the DOACs is quite good in Taiwan, which shows superior to the warfarin. And because now we are having very good medication and ablation tools for atrial fibrillation, and guidelines suggest that early recent control might provide better outcome for patients, for selected patients. So we need to find out suitable patients early, widely, and systemically. Because these patients are mostly symptomatic, so if they don't have symptoms, they may not come to hospital, but they still have a stroke risk. Now we have a lot of novel tools like artificial intelligence, wearable devices, as ECG and BP monitors. We could use them for opportunistic or systemic screening. But in Taiwan, we still have no national screening strategy for the atrial fibrillation. If you want to improve patient outcome, maybe we'll need more clinical trial data and real-world data to prove that this strategy really works. Thank you.
Thank you for your presentation. The third speaker is Zorik Zaidorji from Mongolia. Please begin.
Thank you for the invitation. Good afternoon. I am Zorik Zaidorji from Mongolia. I am honored to present on the key challenges in managing atrial fibrillation in our country. I have no disclosure. Epidemiology in AF in Mongolia. Steps through in Mongolia 2019, the incidence of AF in the 15 to 69 age group is 5.4%. And data from 525 patients admitted to Department of Stroke or hospital with those patients have cardioembolic stroke, and 35% of those patients have with AF is contributing factor. And recent 2022 study revealed that the heart failure prevalence in adults is 4.9%. With 35% also having an atrial fibrillation. And our atrial fibrillation management is a formal national guideline for management of atrial fibrillation has not yet been established in Mongolia. We adhere to European Society of Cardiology guidelines for the management of atrial fibrillation. And the available anticoagulants in Mongolia are currently limited to rivaroxaban and warfarin. And we have been performing catheter ablation procedures for APB in Mongolia since 2016 and cardiac ablation procedures since 2023. The availability of antiarrhythmic medication is limited to digoxin and amiodarone and propafenone. The increasing burden of atrial fibrillation in Mongolia is associated with high prevalence of modifiable risk factors, including smoking and hypertension, physical inactivity, obesity, and diabetes mellitus and alcohol consumption. The current challenges in AF management in our country, in Mongolia, limited experience with registry surveys. While National APB Registry was initiated in 2024, there is currently limited experience in conducting such registry surveys. And lack of specialist APB clinicians or centers, although Mongolia has 3 electrophysiology laboratories. A shortage of trained electrophysiologists and 3D mapping specialists restricts atrial fibrillation ablation procedures to a single center. Challenges with anticoagulation therapy. 2 significant challenges related to anticoagulation in our country are the substantial financial burden this medication places on the patients and instability of their supply, which can disrupt treatment. And thank you for your attention.
Thank you for your presentation.
Hello everyone, my name is Seok-Min Kang from Yonsei University, Seoul, South Korea. It's my great pleasure to be co-chairing with Professor Yukiko Ganano. I'm very delighted to introduce the next speaker, Dr. Don Pham Phuc Long from Vietnam. Please go ahead.
Hello, every colleagues and on the audience. I'm Dr. Long Duong from Vietnam National Heart Association, and this is my honor to be here to give a talk about the Vietnam issues in atrial fibrillation management. So the author have no conflict of interest. So about the epidemiology, we still don't have the national registry about the number of the patients with AF, but this is the summation of some small studies that a population-based study about 1% of populations with the AF. So the Vietnam population is about 100 million. So you can easily calculate that is about 1 million of people having the AF in Vietnam, and more than 80% of that is non-valvular AF. And because of the aging, 9% of the people more than 20 years old have the AF, and more than nearly 4% of people with more than 60 years old have the AF. About the stroke risk, 75% to 90% of the Vietnamese AF currently have the Chak-VAS scores more than or equal to 2 points, and 18% of the strokes having the AF. Regarding the comorbidities, the problems, we have the same that a lot of people, a lot of patients in Vietnam have multi-comorbidities like hypertension, diabetes, and also the coronary artery disease. The management of AF in Vietnam and limitations. First, the rate or rhythm controls. We can do some cryoballoon, radio frequency, and also the DC or medical cardioversion. But for now, the rate is much more outweigh the rhythm control. In Vietnam, there are some of the reasons. One of that is we have 51 EP system over in Vietnam, but we have it's not 20. Sorry, we have 2 system with 3D mapping. It's not enough for the patient in Vietnam. The second is the using of the OAC. So DOACs is now preferred by the doctors, but still limited use because it's just partly paid by the insurance, and also the risk of bleeding because we don't have the antidote over in Vietnam. The anti-Sanet alpha is not available in Vietnam. The lifestyle modifications in general in Vietnam, we have the National Heart Association guidelines for atrial fibrillation management. We have the exercise, obesity, alcohol consumption, also the OSA, the distributed meals, smoking cessations. But it's just talking. But the people, the patient need to be we need to learn from Singapore to have a really practical guidelines. So in conclusion, the AFib is a challenge in present and future in Vietnam, and early diagnosis and community detection to manage risk factors could be appropriate in Vietnam, and the available equipment and supported program maybe from the companies will help us to have the advanced techniques to widely deployed in Vietnam. And thank you.
Thank you very much. Let me move on to next speaker, Dr. Ling Hui Song from Malaysia. Dr. Song, this floor is yours. Go ahead, please.
Good evening, ladies and gentlemen. I'm Dr. Ling from Malaysia. It's my pleasure to share the current trends and the challenges that we face in managing AF in Malaysia. I have nothing to disclose. In Malaysia, we do not have our own AF registry yet, and thus the numbers and the comments here are based on single center reports and publications by some of the individuals. We have about over 30 million populations in Malaysia, and our AF prevalence is close to 1% in the general community. And most of our patients are male and older in age once they develop AF. The stroke rate is about 2%. It is estimated that the numbers of AF will increase by 10% every 3 years in our country, and this is largely due to the aging populations and the high prevalence of DM and hypertension. In current years, we have advanced a lot in rhythm control, especially with the availability of the PFAs and the pulmonary vein isolations of different techniques. And these, in government hospital, a lot of them are subsidized, and part of it needs to go through special government fundings in the public hospitals. And warfarin remains the most prescribed anticoagulant, and our TTR achievement rate is nearing to 67%, and it's been showing slow improvements over the years. There are two challenges that I would like to highlight, and in fact there are a lot. We've seen a lot of discrepancy in the reported AF prevalence among the reports published, and this highlights the potential underdiagnosis of atrial fibrillations. And partly this is due to a high prevalence of asymptomatic atrial fibrillation among our community. And one of the big causes of the underdiagnosis of AF could be due to the lack of AF awareness, not only among the publics, but also among the doctors, especially in the primary healthcare setting. And there are some ongoing solutions that we've taken, and one of it is to impart the active AF screening in our national guidelines of hypertension, where patients with hypertension who are managed in any clinics we need to do active AF screening, and also routine pulse palpations for at least 20 seconds during the BP check to improve the pickup rate of the AF, particularly among the patients with hypertension. And there's been collaborations between our national heart associations with the pharmaceutical companies to drive the awareness among the publics. In Malaysia, we are rich with food and also diverse in cultures, and therefore we are also very rich in terms of the prevalence of ischemic heart disease, diabetes, and hypertension among AF patients. And there has been increase in reports of cryptogenic stroke, which eventually found to be having AF. And this has very much go in tandem with the high rate of the prevalence of ischemic heart disease, hypertension, and diabetes, as these are the substrates that cause more atrial remodeling and later on leading to AF. Besides imparting the active screening of AF among hypertension patients through the guidelines, there has been single-center efforts and to use the non-conventional devices such as wearables, smartphone ECGs, and ECG patches to screen for AF among the patients, particularly in those with cryptogenic stroke. And thus far, this effort has proven to be successful, with increment rate of AF detections and increase of anticoagulation usage in the patients with AF. With that, I thank you for your attention.
Thank you very much. I would like to move on last speaker, Dr. Luigi Pereira Segundo from Philippines.
Okay. Konbanwa, good afternoon. I represent the Philippine Heart Association and the Philippine Heart Rhythm Society as I present the AFib scenario in my country. I have nothing to disclose. We currently have no recent prevalence data nor a national published registry, but in 2003, the prevalence of atrial fibrillation in the overall population was 0.2%, and the greatest proportion was in males more than 70 years old, and that was 2.2% 20 years ago. The closest to a recent data may be from our national health insurance, which is what we call PhilHealth, or Philippine Health Insurance System. In 2017 to 2018, in out of 5.3 million claims, 10,563 or 0.2% were for atrial fibrillation. Let me then present as a proposal a registry from my own hospital, the Medical City, a private hospital of 800 bed capacity, which is an accredited cardiology training institute with about 100 cardiologists, majority of whom actually go to other hospitals in Metro Manila. And so I must say it may be a representative of AFib management in Metro Manila, at least among private hospitals. And in our very young Medical City Cardiovascular Institute AFib registry, of 8 months collection, we have 198 patients with atrial fibrillation. The mean age is 71 years old, with equal 50% are males. 18% have severe valvular lesions, rheumatic diseases, severe mitral stenosis, or with metallic valves. The most common comorbidity is hypertension, present in 80% of our patients, followed by heart failure, diabetes mellitus, chronic kidney disease, and coronary artery disease. 12% were actually confirmed to have obstructive sleep apnea. Among those who are on rhythm control, meaning high-dose antiarrhythmics, most of our patients, that's 43%, followed by a little patients who have undergone DC cardioversion and very few patients who have undergone catheter ablation. We only have cryoablation in my hospital. We have had only 4 cases, but we're part of the global cryo AFib registry. Overall, the whole Philippines, we have done just about 130 cases of catheter ablation. We don't have pulse field yet, just radiofrequency and cryo since 2014. We, however, have a very strong advocacy. We have a PHA Puso Muna, Heart First, that's what it is in English, which is comprised of 11 elements of care prevention advocacy program, some of which are very important in atrial fibrillation. You might want to follow us. You know that Filipinos are very prolific in our social media. And among those are control in blood pressure, blood sugar, weight, exercise, and very recently, abstinence from alcohol, which is very important in upstream control of atrial fibrillation. These are the current challenges of AFib management. Insufficient government insurance reimbursement. For example, the actual cost of AFib ablation in my country is about $18,000, but the government reimbursement is only $400. We don't have registries yet. We hope to share more in the future. And we only have limited antiarrhythmics. Only amiodarone and flecainide are available. This is problematic in the relatively young patients who you don't want to maintain on amiodarone for a long time, especially if they have structural heart disease, which makes them not suitable for flecainide. We have the following action plans. We have advocacy, very strong advocacy and research to hopefully influence policymakers to subsidize more procedures and strategies for atrial fibrillation. We have been starting local registries and are very willing to participate with you in international registries. And we're very grateful that in our support of the young cardiologists, some of our fellows are in Singapore, some are here in Japan, and we hope you continue to take more of our fellows so we can do more for our Filipino patients. Thank you.
Thank you very much for all speakers. Okay, it's time for discussion. I would like to invite panelists to on the stage. Please come forward. Colin Yer from Singapore and Professor Mongunujel Kulebaratar from Mongolia and Professor Gary Lee Chin Kong from Malaysia, Lourdes L. Santos from Philippines, and Kasem Latanasuma Wong from Thailand. So we have 10 or 15 minutes left for discussion. So who's going to start off? So from Thailand, Kasem, short comment.
Thanks for Mr. Chairman. I will discuss about 4 challenging issues about atrial fibrillation management. The first issue is about our local data of the Asia Pacific, a registry or our own data. Because in Thailand, we have some registry about atrial fibrillation. We call the COOL AF in the phase 1 and the phase 2. And we found that in Asian patients have a high risk of bleeding other than in Western country. So the target INR may be different from Western country. If we have our own data, we have to develop some guidelines in our region, such as Japanese Cardiac Society, especially in elderly. The bleeding risk is maybe target INR maybe lower than the patient under 70 years old. I think is the first issue I mentioned. The second issue, I think, is about the appropriate use of anticoagulant to prevent ischemic stroke. Because we found that the warfarin may have some problem about the TTR control. In every country, I think if we have our own data, the control of the TTR is not so good. And DOAC may be better. And in Thailand registry, we found that DOAC have the better outcome than warfarin treatment. But the problem is the expensive than the warfarin. So we have to develop anticoagulant clinic to choose the appropriate use of an oral anticoagulant for the dose and the appropriate criteria and the medication for the proper patient with atrial fibrillation. And the first, I think, due to new innovation and impressive data about ablation technique. But the problem, I think, is not so widely used in all hospitals in our country. So we have to develop for this issue also. And the last, I think, is we mentioned in many young speakers about the holistic approach for comorbidity management and also early screening and detection of atrial fibrillation. Such that I think the Philippine presentation is very interesting for encourage and enhance for the holistic approach for control the comorbidity. Thank you.
Thank you very much, Professor Santos from Philippines.
Good afternoon. So as Dr. Luigi Segundo already mentioned, some of the challenges that we have back home, we do want to reiterate that in the Philippines, the challenge is that we're made up of 7,100 islands. So you can imagine how difficult it is to get across to all Filipino people. Having said that, we do have 6 million Filipinos. Our total population is about 116 million, so 6 million over 65 years old. So this is also a problem that we are facing. There are several advocacies that we've already started on. In the Philippines, you know, we're transitioning to universal health care. Everyone pays for their own health in the Philippines. So this is self-pay, and that's a big challenge. And we're hoping that we can transition to universal health care where we can make healthcare more affordable to everyone. And so with it, the Philippine Heart Association has actually partnered to have some advocacies so that in the universal healthcare, more will be covered than just the $400 that Dr. Luigi already mentioned when we talk about devices. We have a strong advocacy for primary prevention. Again, in a country where everything is self-pay, to prevent will be worth so significantly. And so because of it, we have invested in some advocacies like our social media coverage. So we've actually pushed for some videos so that we can provide a platform for Filipinos where we can fight fake news and we can provide them with a platform where we know they can get educated about health better than what's available there. And I think it begins with small steps. So we've actually gone to schools too so that we can empower children to talk about health so that they can appreciate the value very early on. And so these are little steps that we hope to continue to join in. And we appreciate being invited into avenues like this so we can collaborate, learn more from your countries so that we can also envision ours improving the way yours has. Thank you for inviting us.
Thank you very much. And Professor Mungun Uljil from Mongolian.
Hello. So thank you. Thank you for the chair people and thank you for the organizers for organizing such interesting session. Well, from Mongolia, I would say because we have not too many cardiologists who is actively practicing, it's more or less around 200 to 250. And one of the beneficial part that we have implemented is a telemedicine network within this cardiology community. So everyone who is doing cardiology, they are in our system of telemedicine where we communicate and discuss about our patients. So I think it was more or less not too difficult to change the practice of the cardiologist using, for example, anticoagulants or referring patients for advanced treatments. It was not too difficult because through the system it was quite easier. But now when we are looking at our national data, I would like to echo on the registry, local registry, because we do not have it. We would like to have it. We initiate it. And it will be very important to know how is our patients doing. So we are highlighting on registry. And then recently we also did a CAP survey to understand our population. But we find that many of the patients are having a lot of risk factors. Nearly more than 90% of the population having at least one or more risk factor for cardiovascular disease. And this is, again, quite harsh. And very few of them would like to eliminate these risk factors. So our national center, we are now trying to, highlight more on the preventive activities to reduce risk factors among the population. And on the other hand, also not only to work with cardiology community, but to work with the primary care seemed quite important, especially to improve risk-based management of general populations through primary care seemed important. So these kind of things I would like to highlight. And thank you very much.
Okay, thank you very much. And Professor Gary Riching Kong, Malaysia, please.
Yeah, thanks for the invite. I'm actually Gary from Malaysia. So I would say Malaysia is kind of fortunate and unfortunate in a way as far as anticoagulation of stroke is concerned. Because why do I say we are fortunate? Because we actually have 4 DORADs actually in our country that we can use actually. And that's of course drives a bit of competition in a way. And the fact that I'm saying is unfortunate is because most of our public services are still very much using warfarin because of the access to it, because it's still costly. Because the public reliance on the public healthcare is quite huge. It's not really subsidized in a way, it's fully reimbursed in a way, I would say. People are just paying 1 ringgit or 5 ringgit or Malaysian ringgit just to access to this public healthcare. So, but I believe with time to come in a year or two when now the generics are actually coming through into the Malaysian market, I believe, the government will set forth where they're going to purchase more of these generics DORADs for the public patients to be used. So therefore, I think from a very unfortunate situation, we're going to move into a more fortunate situation as far as the public patients are concerned. But whereas for the rhythm control for AF itself, I would say, we still have much to do in Malaysia because there are not many public centers where we can actually afford to do catheter ablation. Even those centers which we are able to, we will still have a long waiting list. Of course, again, very similar to other countries, we have both private and, of course, public services. The private services are not much of an issue when we talk about catheter ablation, but for public patients, they probably have to wait anywhere from 6 months to a year before they get a catheter ablation. That's why, nowadays, our Malaysian Heart Rhythm Society, we've actually been advocating through our forums and conferences to our general physicians, who are in district hospitals or in rural areas, before they get the patients into us, they might as well consider to cardiovert the patient to buy time. So we are really emphasizing a lot on electrical cardioversion in these district hospitals so that we buy patients some time to prevent more detrimental changes within the heart chambers itself. Because by the time they reach us, if they are already, going to very severe heart failure, probably that will not be a very feasible opportunity for us to do any catheter ablation. So I would say, we are still very much in infancy as far as catheter ablation is concerned, but I think we're really moving forwards to it. And hopefully with the pulse field ablation now being embarked in most of our centers now, we can have faster turnover time, but the cost has to come now. Otherwise, the government again will back to square one where they have to subsidize heavily for the public health care. Thank you.
Okay, Professor Colligno, do you have additional comment?
Okay, I'll make it a very short one. I think my message was very clear. We really cannot be just relying on tertiary care. We really, as I echo a lot of my colleagues here, the education is important, empowering with primary healthcare is important. So don't kill yourselves with overloading yourself, but really be an advocate and try to share the reasons why we should treat AFib early, and ideally to really advocate for healthier lifestyle if we can, to prevent or delay the onset of AFib to begin with. Thank you.
Okay, so I think we have reached the time. So I have a short comment with the closing remark. So I'm a heart failure specialist. From the point of view as a heart failure specialist, one thing I would like to say, as we all know, the AFib and heart failure have a common risk factors and a common pathophysiology with the increasing prevalence in Asia Pacific area. But we still some knowledge gaps between heart failure specialists and EP physicians in terms of management of strategy in various clinical settings. Evaluation first, GDMT first, rhythm control first, rate control first. So even in clinical practice, sometimes we don't know which comes first. Heart failure first, AFib first, in patients with heart failure with AFib. So one more thing, in my opinion, the diagnosis of heart failure is often overlooked in patients with AFib who visit first EP physicians. So in this regard, we should collaborate with exchange of knowledge and sharing the experience according to the current guideline to improve management of AFib patients, especially in heart failure. That's my point of view from heart failure specialist. Anyway, so time's up. So we thank you, everyone, panelists and the speakers and the audience. We really appreciate. So I close this session. Thank you, everyone. Thank you.